everyone. Thank you for coming. I'm going to speak to you today about this new book that I've written with Michael Seltzer. Both of us have many, many decades of experience working with psychosis, both inpatient and outpatient. In the introduction, I write that together we have 100 years of experience. So it's quite a bit. Not just working with psychosis, but teaching it, training people, supervising, and writing about it. So we put our heads together to write this book, and as a guide for professionals who wish to know more about how to work with psychosis from beginning to end, from the first contacts all the way through to termination and even supervision, how to supervise young people, young professionals who are learning to work with psychosis. So let me just tell you about the title, From Breakdown to Breakthrough. I had a few titles. At first, I thought of Unraveling Psychosis, and then I thought of Coming Undone. And even though I liked the sound of those, I didn't like that they were so one-sided, that psychosis unravels, although it had a double entendre that we therapists had to unravel the meaning of psychosis. Coming Undone, also, it was very one-sided, more about the breakdown side of things. And we wanted to show how this, through our treatment, the whole point of the book was to show that treatment can help, and therefore the breakthrough. One of my patients, the patient I write about in chapter 10, I give a complete description of my 20-year treatment with this patient who had 3 psychotic breaks. And he then writes his own reaction to my piece in the book. And at one point, Josh, as we call him in the book, said to me, "I'm not sure if I'm having a breakdown or a breakthrough." And we both talked about that several times, whether the breakdown could lead to a breakthrough. And so that's where the title comes from. I think it's significant. And it is meant to show that psychosis is treatable by psychoanalytic means, something that many in the medical profession do not believe or adhere to. So, Winnicott also, D.W. Winnicott also felt that sometimes one had to regress or go through a breakdown in order to break through a place where one is stuck, has been stuck. Afterwards, Bion in 1975 gave a lecture which he titled Break Up, Breakdown, Breakthrough. I only discovered this after the book came out. Mike Eigen pointed it out to me. Mike Eigen wrote a book called The Psychotic Core, explaining how all of us have a psychotic core. Even Sigmund Freud wrote that we are all psychotic when we dream. And he felt that certain aspects of psychosis, megalomania, retreat, regression, restitution, are all aspects of psychosis that everyone has at one time or another. And Carl Jung wrote once that a great psychologist is someone who must spend his life in a mental hospital. The question is whether as a doctor or a patient. Again, showing how we all have this, and it can manifest this way or that way. So what are these psychotic experiences, in essence, that we all have? And they essentially intensify this silent fragility inherent in the ways we constitute experience of ourselves, of others, and of the world. Now, why are we so afraid of this? Why are so many people reluctant to do this work? And, I can't tell you how many people, colleagues of mine, tell me, how can you work with psychosis? Aren't you afraid? All kinds of, stigmas associated to working with psychosis. And this, again, was one of the reasons why we wrote this book, to destigmatize not just psychosis, but the work with psychosis, and to make it much more approachable. So we wrote this book because we realized that the majority of mental health practitioners do not treat psychosis. And I know this because I get a lot of referrals, and I have a very limited pool to which to refer. It's not taught in medical institutions. Psychiatrists don't learn that. Not only they're the ones who are often working with psychosis from a medical model, but they don't learn therapy, how to do therapy with psychosis. University programs in clinical psychology and social work often have no classes on working with psychosis or extreme states. Psychoanalytic institutes, almost no classes. Many of them won't allow you to use a person with psychosis as a training case. They feel that it's not applicable. So there's a huge bias against learning about and doing this work, which I feel that we're trying to overcome. It wasn't always the case. It wasn't always the case. Initially, prior to this, psychoanalysts were in the forefront of treatment of psychosis. Chestnut Lodge, I'm talking about in the United States, in Chestnut Lodge, a huge hospital near Washington, trained and treated psychosis. The entire hospital was just for the treatment of psychosis. Frida from Reichman worked there. She lived there too. She lived on the premises. Harry Stack Sullivan gave seminars there, weekly seminars. Otto Will, Harold Searles, Edward Podval. So many well-known psychoanalysts worked there, trained there, and their motto was that no one is hopeless. No one. And so you go in, and they were given a lot of liberty about how to approach the treatment of psychosis, because they understood that every individual is different and unique, and one sometimes has to, be very creative about how to reach these people and help them with what they were struggling with. I'll talk about that a little later, the creativity that is needed in this work. But we had Chestnut Lodge, we had the Menninger Clinic, we had Austin Riggs, we had a lot of the psychiatric inpatient units. The attendings were psychoanalysts. So what happened? What happened? Well, what happened is psychopharmacology and the drugs, the antipsychotic drug revolution, and the theories that came about claiming that psychosis was different from other psychiatric conditions, in that it was more biological and therefore, or a chemical, they called it a chemical imbalance. It was a biological disorder, and therefore it needed to be treated with drugs and only drugs. And in America, not everywhere, in America, we handed over the treatment of psychosis to psychiatry and psychopharmacology. And it's pretty much been that way for decades, except for a few of us. We're like this little club. And ISPS is one of our homes, which is wonderful that it exists. But let's see. Even certain people who claimed that psychosis was completely biologically driven and a chemical imbalance, like Nancy Andreasen, she backtracked and she said it was wrong, that a lot of these theories were not substantiated over time and with research, but they have stuck nonetheless to a large degree, unfortunately, and they've left a bias behind them. Our book is trying to undo that bias and reopen the doors to psychoanalytic understanding and treatment of psychosis. So, that's the reason we wrote the book. And even people who want to work with psychosis, the problem is they don't get the training and they feel ill-equipped to work with psychosis. And that's, why we take it step by step by step by step. This is my 10th book. It's the only how-to book I've written. And it's really there to guide people through and help them with tons of examples, clinical examples, so that you can see how this work is done. So if they're ill-equipped, our goal is to equip them. The other thing I want to say is Edward Podval, who worked at Chestnut Lodge, who worked at Austin Riggs, he was a Buddhist psychoanalyst. I don't know if anybody's heard of him. And he was a wonderful, wonderful man. In the end, he left everything and went to France and lived in a monastery for 20 years. But before he did that, he wrote about islands of sanity, islands of clarity. All of these authors that I've mentioned claim that no one is psychotic all of the time. No one is 100% psychotic, just like no one is 100% normal, whatever that means. And so what he said is you have to take a history of sanity, not just a history of psychopathology. So often with the medical model, what their interest is in symptoms, how long have you had these symptoms, how severe are the symptoms, what drug do we match to these symptoms. I have to close this so I'm not distracted by the chats, but feel free to write in them. Okay. So he says a person is a whole. We have to look at the person as a whole person, and that includes taking a history of sanity. What did this person do before? I've heard of so many cases of people who were hospitalized and treated at their lowest, possible functioning level. And only much later did they find out that this was a famous concert pianist or writer or whatever else. But they never asked about the high functioning. They only asked about symptoms. And so that's all they knew about someone. So one has to look at areas of sanity. And Podval designated 5 areas of sanity or clarity. There are many more, but here are his 5. The first is repulsion. When somebody who is experiencing psychosis, it also expresses some repulsion towards their own psychosis, meaning they want to separate from it. They want to get rid of it. There's something that they want to go beyond themselves. That's number 2, a very Buddhist kind of thing. Number 3 is discipline. Do they show some areas of discipline? In mental health, we don't talk enough about discipline and the value of discipline. But people who can show some discipline in life, whether it be cooking, gardening, writing, adhering to any kind of schedule, that portends very positively for someone who can attend therapy sessions, right? We need a certain amount of discipline to function in life. Number 4 is compassion. Does the person show compassion to others, towards oneself, towards animals, wherever you can see that compassion, towards the therapist, right? That is a very positive sign. And finally, courage. Courage. Bertram Karen, who is very well known for his work on psychosis, once wrote that the only thing you can be sure when you're dealing with psychosis is that the person is afraid, that there's fear. That's it. So if that's it, then when we see some signs of courage, we have to take note of those, because that's something very positive. I'll give you an example of a patient of mine who revealed to me after several years that when she came to my office, there were hundreds of rats in front of the office that prevented her from entering the building. Hundreds. And so she had to come like an hour in advance until she noticed a little pathway. The seas parted, and she noticed a pathway and ran in to come up and see me. Now, notably, she never missed a session. She was always on time. So somebody from the medical model will say, oh, okay, she's hallucinating these rats. What medication should we put her on? But what I saw was the enormous courage that she showed, because these rats obviously symbolized some danger, some negativity that she had to face when she came to therapy to work on her own issues. And she struggled and fought through them to be able to attend the therapy. Now, those were signs of courage. So courage isn't always like straightforward. You have to see it also sometimes in these unusual ways in order to recognize and value that these are signs of courage. Okay. Let me move on to symptoms. Since symptoms are often the first thing we see and the first thing that allows us to diagnose psychosis, symptoms are very important. They're not just important to psychoanalysts, they're important to the medical model, to psychiatrists, psychopharmacologists. They take an enormous interest in symptoms. What symptoms do you have? How severe are they? When did they begin? How do they respond to the medication, etc.? It's very symptom focused. CBT is also very symptom focused. And the thing about medical model and CBT is both of them approach symptoms in a way to alleviate, to reduce symptoms, and even try to eliminate symptoms. The difference with a psychoanalytic treatment is that that's not what we do. We don't rush to eliminate symptoms, because symptoms are what a person presents us with. And therefore, that's where we get the information that we need to get to know this person. So we see it more as a way in to a person's subjective world and how they make meaning of their lives, their issues, their problems. So if you eradicate the symptoms, you lose this vital opening and create, not only that, you create a patient's mistrust in the therapist, because this is who they are, this is their life, this is what gives them meaning, and then you're taking it away from them. This is one of the reasons why many people, maybe around 50%, at least 50% of people with psychosis who are put on antipsychotic medication stop taking their medication. It's part of it is the side effects, some of which are terrible, but part of it is because that's where their meaning is. You've just taken it away, ripped it away from them, and they're left without meaning. So we see a patient's psychotic symptoms as a sign that a human being is fighting for their life. So we also see it as, we meet the patient where they are. If this is what they're presenting, that's where we're going to meet them. And we take what we can get. We take what we get and we meet the person there, and we start where the patient is at. We show a respect for symptoms. We give credit to the patient's struggles that via their symptoms as efforts, however flawed, right, at adaptation and caretaking and coping, right? These are coping mechanisms. These are adaptation attempts, and they're attempts to take care of themselves, to attenuate affect. They have a heuristic value. They have a meaning making. If you take the time to try to understand what the symptoms are saying, and I'll give you a few examples, then you will see that there's meaning in them, just like dreams, right? In the beginning, people would say, oh, it was only a dream, as if there was no meaning to the dream. Same thing with psychotic symptoms. People will say, stop talking gibberish, or this isn't real. But that's not addressing what the symptom really is and what it means for the person. So if we take the time and the interest to figure that out with the patient's help, then we can, A, build an alliance, and B, understand much better where the person is coming from and how to help them. So a lot of people think that the symptoms hide the real person, right? But we think the symptoms actually reveal. They're a window to the person. The other thing that we disagree with is this whole notion of a psychotic break, as if there was a before and an after. And a lot of people, including family members, always say, well, I wish the old Eddie were back. Or I wish as if these are two completely different people. But this is one person who has gone through something and come to another place. So instead of seeing symptoms as break, we see it as a bridge between what was before and what came after. If we see it as a bridge, then we can help a person develop a narrative of their life and how they went from this to this, right? It also establishes the authority of the patient. We're giving the patient credit that they know about themselves, about their lives, about their minds, rather than we playing the doctor and telling them, what's wrong with them and what they need to do. So there's an intelligence, there's a logic in symptoms, and there's an attempt to communicate, no matter how confused or bizarre, they are an effort to reveal something. Now, when I'm talking here, I'm talking mostly about positive symptoms, right? Hallucinations, delusions, disorganized thinking. For many people, when they think about psychosis, they immediately think about positive symptoms. But there's also negative symptoms and that are associated with psychosis. And we need to look at that as well. And those are treated differently. You can't treat everybody the same way. They're presenting differently. You have to approach them differently. So the positive symptoms are more flamboyant. They catch people's attention. They bring people to treatment, right? Some identify psychosis with hallucinations, disorganized thinking, and delusions. But the negative symptoms refer to a lack or an absence or a deficit, right? A lack of energy or drive or involvement or interest, a lack of motivation, a lack of purpose, a lack of pleasure. You see this with blank faces, with monotone speech, with no eye contact, right? These people are usually more reclusive, less communicative, less related in general. A lot of times these people are you're told that, well, they're hopeless. You can't reach them. They're called the unreachables, right? So therapy plays an active role with positive symptoms, but like I said, more people view patients who present with negative symptoms as untreatable, more difficult to reach. The Lacanians write about what they've termed white psychosis or quiet psychosis. Darian Leader says that you can be mad without going mad. Now think about that. The going mad is the positive symptoms. Here I am, I'm mad, look at me. You can't, but you can be mad quietly, right? And there are many people with quiet psychosis or white psychosis. Unfortunately, these are the people who are most often ignored in treatment. They're hard to reach, it's true, but are they unreachable? We would say no. Yes, there is an absence, what's hidden, there is an effort to retreat, to hide, but one needs to understand that the desire there is not to be known, it's to not be overwhelmed. The world is viewed as a dangerous place for these people, and they retreat because they're afraid of being overwhelmed. And so in working with these kinds of cases, you need to tread very gently and slowly, and you need a lot of patience. I give an example of a patient I worked with for 19 years, 16, 19, somewhere around there, who was, for the first years, silent. We sat in silence together until very slowly, he began to feel safe, and I tried very much not to intrude. So sometimes, and I tell the entire case of this treatment also in the book. Many people feel dead. They'll tell you, some will say, I'm dead. Can't you appreciate this? Or they'll feel dead. And it's difficult to appreciate the function of deadness if one is focused on eliminating it, right? One has to understand that if somebody feels dead, they cannot be affected. They cannot be harmed. They cannot be hurt. So what happened to them that they got to the place where they have to armor themselves to that extent, to deaden themselves, deaden their needs, deaden their desires to that extent. And some people say, well, they've given up on life. No, if they're putting that much energy into keeping things out, that energy is already a life force. So again, you have to think differently when you're looking at different kind of psychotic defenses. I'll give you an example from Frieda from Reichman, who said one never gives up on a patient. And she had a patient who was all negative symptoms, very reclusive, didn't come out of his room at Chestnut Lodge, and wouldn't talk to anybody. And so what she did is she took her chair and just sat outside of his room every day at the same time. Again, discipline, schedule, but there she was, predictable, consistent, reliable. And he just ignored her. She was an object, just like the chair, for day after day after day, week after week, month after month, until one day he looked at her and he said, "What are you doing here?" And she said, "I'm waiting for you to talk to me." And there began the treatment. So if you don't give up on somebody, eventually they crack open that armor. And then if you treat it with gently, you can slowly build an alliance and rebuild a trust in that person and discover why that trust was so damaged that they had to retreat to such a to such an extent. So everything I'm saying requires creativity, requires looking at treatment somewhat differently, and differently for each person, right? So even if you know psychoanalytic theory and a technique, therapy technique, it doesn't mean that you can just go in and say, oh, I know what to do now. No, the whole point is that you have to take your cues from what the patient is telling you or showing you and accommodate to that. So it's challenging in that way. There's a lot of countertransference. People have fear of having commonality with the patient, identifying with psychosis. Some people, Sullivan talked about contagion, that some people are afraid of catching psychosis. It can surface traumas in the therapist, losses, abuse, a deadened relationship with a caregiver, disappointments, memories of abandonment, of losses. One has to provide holding, containing, mourning, allow mourning, helping someone feel safe, understood, without intrusion. And then eventually, if you have the patience to do this without invading someone and taking your cues from them, they will emerge from their retreat and relinquish it. And both you and the patient survive that deadness. And that means a lot to both of you, actually, that you both can emerge from that. I see it's already 39. Okay. In connection with negative symptoms, but not only, I want to say a few words about loneliness. We know that there's a loneliness epidemic in the world. There are loneliness ambassadors in many countries, in Japan and South Korea, in the United Kingdom, in Singapore, New Zealand. They have lonely, so it's recognized. It's recognized here too in the United States. Loneliness is critical in particular, not only, but in particular to psychosis. Frieda from Reichman and Melanie Klein's last papers before they died were on the subject of loneliness. Patients diagnosed with psychosis are 6 times more likely to feel lonely than patients who are not diagnosed with psychosis. So they're huge, the numbers are huge. Just like Bertram Karen said, fear is a given when you're working with psychosis. I would add that loneliness is a given when with psychosis. The general population claims that they're lonely, 35% of the time. People diagnosed with psychosis claim that they're lonely between 75 to 93% of the time. So there's a huge difference. So what is loneliness? Loneliness is a universal human experience. Sullivan said it's the most painful experience that humans feel. It's wrought by the significant gap between one's actual social relationships and one's desired social relationships. Now, Freud claimed that you could not analyze a person who experiences psychosis. Why did he say that? He said that because he felt that the person with psychosis could not develop a transference. And without transference, you can't do psychoanalysis. That was his thinking. Later, he said other things. He often had different opinions at different times. But he was very interested in psychosis and psychotic mechanisms. He was less interested in the treatment, and partly was because he saw them more as in retreat, not being able to connect. But what I've found is that patients with psychosis connect in unusual ways because of that loneliness, that sense of loneliness, they find ways to connect in ways that we don't initially perceive that they're trying to overcome loneliness. So, for example, people who have hallucinations, they often, a lot of people think that people with hallucinations want to get rid of them. Not everybody wants to get rid of their hallucinations. Many times these auditory hallucinations are members of family that they've lost. They keep them company. They're positive figures in their lives. Some people have positive and negative hallucinations, but don't assume that they're always negative and that people always want to get rid of them. And I think the Hearing Voices Network is very valuable here because they don't just aim to, let's get rid of all hallucinations. Let's live with them. How do we live with them, right? And how do we make the best of it? So extreme loneliness can trigger psychosis. If you put somebody in solitary confinement, they will develop psychosis. Any person, as normal as they can be, right? They will develop psychotic symptoms. So it shows that loneliness, retreat, that disconnect from other people and the world can create psychotic symptoms. Institutions, when you institutionalize people, when you medicate them, it alienates them from loved ones, from their environments, and from themselves. How many people I've seen who came out of hospitals who told me they don't know themselves anymore. They can't connect with themselves because they're so overly medicated. Delusions too, paranoia, thinking that someone is always after one or interested in one. One can see that as, okay, it's a psychotic symptom, but it's also a way of not having to be alone. At least people are interested in me. They're following me. I'm never alone. I always say paranoia means never having to be alone. There's people, the worst thing is indifference, that people will be indifferent. But with paranoia, with delusional systems, there are people constantly invested in you, invested in what you're doing, following you, interested in what you have to say. So if you see these ways that people with these extreme psychotic symptoms may be attempts at trying to connect, even in their strange ways, you will intervene as a therapist differently, because then you can talk about what they're trying to get rather than what they're trying to get away from. And it will make a world of difference to the person with these experiences. Tell me when you want me to stop. I have, other things to say, but if you want me to stop and open up to questions, should I go a little bit longer? Yeah, okay. I have different topics. Creativity and psychosis. This is a very important topic. I've written a lot about creativity and art and the creative process. One of the reasons I love working with psychosis is because I've always been amazed by the creativity in the psychotic mind to create alternative worlds, to find ways to, creative ways to cope with reality, like the rats, like creating these rats as obstacles, but also as something that can be overcome. But also the creativity required in me as the therapist, as the analyst, to try to understand, reach someone that's not so, I can't just use straightforward methods. So I find it a very creative work. It's a work that demands a lot of creativity of me, which I like because I'm a creative person. And so if people like to be creative, I think that this work really offers a lot of opportunity for that. Let me give you examples. I had a patient who I had a charcoal drawing at the entrance of my office of Marcel Marceau. Marcel Marceau was then the most famous pantomime artist, a French artist. And the drawing was all black, background back, but like pantomime artists, the face was white and the gloved hand was white. And so you just see this white face and hand, and very expressive, because they're very expressive with their faces. And the hand was like this, reaching out. Okay. I had a patient who would walk in every day and nod to Marcel Marceau. And she told me they were two of a kind. She bonded with, she almost ignored me, but came in and nodded to the drawing of Marcel Marceau. One day, several years into the treatment, she walks in, she sat down, and she said to me, Marcel Marceau is dead. Dead. Now, I knew he was old, but I hadn't read the news that day, so I believed her. I was like, okay, Marcel Marceau died. That's sad. And then halfway through the session, suddenly I see her going like this, as if she's watching a tennis game or something like that. So I let it go on for a little, and then I said, what's going on? And she said, don't you see? And I said, no, I don't see. Tell me what you see. And she said, well, there's a homeless man in your office, and he's mute. And I said, oh. And I said, but why were you moving your head back and forth? And she said, well, he keeps scurrying back and forth in your office. And he comes all the way right up to you, to your legs, and he puts his hand out, almost touching you, and then he runs back. So here she was showing me the same gesture that this homeless mute man was making with the gesture in the Marcel Marceau drawing. So she killed off Marcel Marceau and created this homeless mute man that was expressing something for her in the office, some need for closeness to me, yet also a fear that she would run back. Here's a psychotic symptom that let's just medicate that away. No, this is so rich. It's so rich in meaning, and not just her personal meaning, but meaning to the treatment, because I became part of this too. And this homeless mute man was with us for 3 months in every session. And I began seeing him, to tell you the truth, because I knew when he was near. But it really became something. She was allowing me to see something that I wasn't seeing, which was her hunger for closeness with me, her hunger, her feeling he was homeless, her feeling of not having a home, of the loneliness, right? All of that was being expressed in this hallucination, right? And had I just medicated that away or seen it as a psychotic symptom that had no meaning, what a loss to our treatment and to our beginning to understand what she was trying to tell me that she didn't have words for. So she was letting me see something that I couldn't see, and I was putting words to it and giving symbolization to it. He wants closeness. He's lonely, I would say. So I put words to it, and she gave the visualization to it. Here's an example. I give this as an example of the creativity both in the patient and their psychotic symptoms, and in the analyst who has to, find creative ways to work with that kind of material. And we lived with this, our treatment included included this psychotic mute man that I began seeing. It was a kind of folie à deux. I had to enter her world. I had to be able to see it. And it was very important at that point in treatment because she was telling me something that she needed from me and that I wasn't seeing. And it was a very effective way of getting through to me, and also a very creative way, a visual way. So that's an example. Another example, and this is of a patient of Michael Seltzer's that we include in the book. These patients are in the book and more, is of a woman who was hospitalized, and she hallucinated having 17 children. 17 children in her hospital room. And when Michael approached her, he opened the door and she, screamed at him, "Don't step on Tony." And of course, he didn't see Tony. Same thing as the mute man. But he backed off because he recognized that for her, there was a Tony there. And so he stayed outside of the door and for a while just, let her know that he got the message that there was danger, that she was taking care of children, even though he couldn't see them. So even if you don't understand everything, you can immediately understand two things here. One, she felt there was danger, and two, she was in the role of a caretaker. Now, little by little, with the treatment and building trust, he discovered that there were 17 children in there. All of them were under the age of 8, right? And she lost her mother when she was 8. So she was transferring this caretaking to these orphans that she saw as orphans as a way of taking care of her child self. But little by little, she needed to let them go in order to have a life herself. And it's a fascinating treatment. So these are examples of the creativity of symptoms that if you just rush to eliminate them, you lose so much information, so much meaning. You lose the trust. Imagine losing the trust in the relationship with the therapist, and the therapy will be completely different because you have less to work with, a lot less to work with. So that's those are some examples of the creativity in the work. I think, I have a lot more to say, but why don't we stop here and open it up, and people can ask questions or give comments or add examples. I'm happy to hear what you have to say.
Thank you so much, Danielle, for that great talk, which really, to me, highlighted how deeply you seek to connect with those you work with. That really came across strongly to me. Before I hand it over to Kaki to maybe go into the Q&A box, and please, folks, if you're reflecting and thinking now, put your questions in the Q&A box. I'm just really curious. What led you to this work, Danielle? And the piece at the beginning where you said, so many therapists don't want to do the work or don't think this work is possible. What led you to be a therapist, but then also seek to work particularly with people with psychosis in extreme states?
I think it's one of the things I mentioned earlier. I'm a creative person. I've always been interested in creativity. When I decided to be a psychologist, it was a decision. I either become an artist or a psychologist. And my solution was to become a psychologist, but still dabble in art. But what I found was the most satisfying is to bring to bridge the worlds of psychology, psychotherapy, psychoanalysis, and creativity and artistic creativity. I'm going to give a talk in April on creativity and psychosis. I gave you a little taste of it. So I think I was always fascinated by the creativity in the psychotic mind, the way, the extremes of, you know, human experiences, how people creatively try to cope with adversity, and how I needed to use my creativity to reach and to understand them and to build an alliance with them. I found it very challenging. I like challenges, and I don't like just working by the book, even though I wrote a book that you can work. But it's not a book that says you have to do this, 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 this. It's not a manual. It's a guide that says, here, this is what you pay attention to. This is how you, but the way you do it, the way you find to do it has to be your own. We just highlight ways that ways in, right? So that's really what attracted me from the beginning. I've always been attracted to that. I like challenges and I like creativity, both in patients and in myself. And so that's what drew me to this work and still does. Yeah.
Thank you. I can definitely relate to some of that. Okay, Kaki, do you want to take some questions from the audience?
Yes, let's see. While I'm moving up here to the questions, I'd like to say that I too benefit as a transition age young adult from a psychoanalytic professional. I credit her a lot. The beginning of my recovery. So Eden Alexander notes that she's interested in doing therapy with people who experience extreme states. She'd like to do it outside of community mental health or hospitals, and she wonders about doing this through private practice. Is there a way to do that?
That's a good question. That was one topic I had that I didn't talk about, but I'll do it now in response to this question. One of our chapters in the book is on inpatient versus outpatient work. Emil Kreplin, who was Mr. DSM, it's from him that this whole diagnostic categorization came from. In 1919, he developed his ideas about what he called dementia praecox, which later became, psychosis or schizophrenia. But he developed his ideas in a hospital setting. And this led to an equation of psychosis hospital, unfortunately. As if, and many people think that as soon as somebody says, I have a hallucination, they think they have to be hospitalized, which is bullshit. So there was very little on outpatient work with psychosis. Now, hospitals have changed over time. There was a time when I trained, you could work psychoanalytically. I had patients for 5 days a week. I decided if they needed, medication or not. They could stay for long periods. We really did in-depth work over time. And now the hospitalizations are, 2 weeks at most, and it's in and out, and they're really concerned only with harm. Is the person causing harm to the self or other? And then they're out. If they're medicated, usually over-medicated, and then discharged. So hospitals, they're necessary for people who are in danger or in danger to others. But they're not really the places to get therapy or treatment. And many of them don't give treatment. They don't give therapy. They're groups. A lot of the groups are take your medication groups. So they're very, focused on one thing. I've had many patients who were hospitalized briefly and came out overly drugged and got absolutely no therapy, none, not 1 hour, not 15 minutes. So what's the advantage? The advantage is that it creates it's a safe space. If someone is in danger, the danger is controlled, and it's it's a way to deal with some very strong negative behaviors. In the outpatient treatment, if you're taking on patients with psychosis in outpatient treatment, the safety becomes the responsibility of both parts, the patient and the therapist. So you have to assess, danger, safety, when you take on a patient. You don't want to take on a patient in outpatient treatment if you're worried about what the patient is doing between sessions. So there was one person we talk about in the book who in between sessions would be, would take the newspaper and expect to see his patient killed his mother in between sessions. Not a good thing. If you're that worried about your patient as an outpatient, then, you're not going to feel comfortable working with somebody like that on an outpatient basis. So, but the good thing about working on an outpatient basis is that the person can continue living where they live, working if they're able to work, and many are. In a hospital, it's like they have to function at the lowest level of their functioning. Whereas on the outpatient level, they can keep a higher level of functioning so that the transition is not so great. It shows the therapist faith in the patient's capacity to get better. There are additional environments and people that can help and continue and support the work. Each needs the other. The patient and the therapist make up the rules. I mean, in Finland, the open dialogue system is to keep people out of hospitals. And they've been quite successful with that. And how do they do that? By keeping patients in their family environments, minimal drug involvement, and a lot of talk, a lot of dialogue, and people involved with the person's improvement and getting better. So you take care of the safety and the isolation from an outpatient basis. But those are the two critical keys to taking on patients with psychosis on an outpatient basis: safety, isolation. And I'm talking about the isolation of the therapist, because you don't have a team. So I think that people who work psychoanalytically or therapeutically with psychosis on an outpatient basis should have like a group. I even belong to a group of senior analysts who we have like a peer supervision group that we present to, because there's so few of us. It's good to get that feedback and that support when you're doing this kind of work. It is challenging. It's rewarding, but it's challenging. So I encourage you to pursue this, but know what's involved so that you can enter this kind of work with the knowledge and with the preparation to do it well.
Thank you. So both in the question and answer and in the chat, there has been some dialogue about spiritual emergence, existential crisis, where are the lines, is this both and? I'm just wondering if you might speak in general to that area.
It's a kind of vague. I'm not sure.
Yes, okay.
The
Well,
question.
here's one.
Give me a more specific question.
All right, I will. I'll choose one.
Okay.
So, is there a line to draw between something like a spiritual emergence / emergency and psychosis? Or could it be more of a both and thing? Does a person's belief system in terms of spiritual or non-spiritual or religious, with various possible persecutory factors, make a real difference on outcomes and meaning making?
Well, I'll answer it the way I can. And that is that we often do encounter spiritual elements, emergences when working with psychosis. How do you handle very existential issues. I see those as somewhat different, the existential issues, life or death, mortality, and the spiritual. Many people think they're prophets or Jesus or Moses, or, people will identify with spiritual leaders in their psychosis. And one just approaches it the way one approaches it. What does it mean? What is it, what is their religious background? How is this feeding into this? Why now? Is it an overcompensation for an insecurity that now they're all-knowing and omniscient and can do things? I mentioned a patient in the book who came to me and said, well, if he thought he was a prophet, but then at one point he said, well, if I'm a prophet, so there's that, like, if. That's an opening. When somebody says, if this is true, that means there's a part of them that says, well, maybe it's not, right? But that doesn't mean you pounce on that and say, caught you, maybe you're not a prophet. You just think you are. No, you just, can explore with them the question or the doubt or wait and see. Many prophets in the Bible would be considered schizophrenic today. Where is the line? Where's the line? It depends what you believe, right? Of course, it depends what you believe. Many people have spiritual delusions. Many people have sexual delusions. A lot of that has been found to be related to what a person's background is, interestingly enough. So I'm not sure how much more to go into that, but it's a big area. For example, in Israel, there's a Jerusalem syndrome. I don't know how many of you have heard of this, that tourists who visit Jerusalem, this very holy place for 3 religions, develop psychosis when they're there. And there's a hospital that knows this and brings these tourists to this hospital, and they're treated for Jerusalem syndrome. It's like a place that's so holy that it brings out, extreme reactions to being there, just to being there. So is spirituality, can it be part of this? Can it express itself via psychosis? Absolutely. Absolutely.
So an anonymous attendee asks, do you see a connection between extreme states or serious mental illness and poverty? How do you grapple with this in terms of access to care?
Good question. Yes. The answer is yes, that I think all adversity, first of all, statistically, it's been found that someone is 4 times more likely to develop psychosis if they live in an urban environment than not. Now, why is that? Urban environments, people live in crowded spaces, they're more likely to be poor, there's more likely to be crime, there's more likely to be drugs, so all of these things that occur increase the probability of developing psychosis. So there definitely, just statistically, is a connection. The more adversity someone has in life, the more likely one is to develop psychosis, because the more adverse, the less a person develops strong coping mechanisms. And part of the way that someone adapts to that or tries to cope with it is through extreme measures like psychosis. So that's very, very important. And also, it's important to know that people who come from poorer backgrounds, immigrants, are more likely to be diagnosed as schizophrenic than non-immigrants. So just because someone like might not understand a culture or the immigration experience is very stressful, many times it's extremely traumatic for people. Trauma, I was telling you how the medical model decided that psychosis is different from other disorders because it is biological or chemical. But what we've discovered these last few decades is that there's a very high incidence of childhood trauma in those who develop psychosis. So that's very important. And people never used to ask, and probably a lot of them still don't ask, about trauma background when they encounter someone with psychosis. Many times, what we're seeing is a post-traumatic response to an abusive situation. And that needs to be understood when we work with somebody. If you've had an extreme experience growing up, you will have an extreme reaction to it. And so you have to put those things together rather than just say, well, this is a biological and this is psychological. Poverty is one of those things. Yeah.
Very much. Can you speak to the role of shame in relationship to psychosis?
Whose shame? The person with psychosis?
I would imagine, but does not say. That is the entire question.
Shame. Well, there's shame in feeling many things. Shame can be related to many aspects. It can be related to the fact that the person does not fit in and may feel that early on, that they're not like other people, that their reality is not the consensual reality, especially in middle school, high school, when there's so much pressure to be like everybody else. If they're shunned by, the group, they can retreat and become more isolated, and that can develop shame. If they're not progressing the way other people their age are, that can create shame. To acknowledge that someone has been diagnosed with schizophrenia or a psychotic disorder or been hospitalized for one can also cause people to feel a lot of shame. So when you're working with people, it's very important to understand, like I said, the loneliness of the condition, the stigma associated with the condition. This is why, a lot of people want to get rid of the word, the label schizophrenia. I only use it in the book when the author is using it, who I'm speaking about. Otherwise, I talk about psychosis or psychotic episodes or psychotic symptoms, not a psychotic person. Because a person is not psychotic. They might have psychotic symptoms. They might have had a psychotic episode, but no person, like I said before, is 100% psychotic. So we have to be very careful with the terminology, but in life and in the medical establishment, people are not careful with the terminology. They throw out these labels left and right, and there is shame and stigma associated with the labels. Now, the therapist also might feel shame. They might feel shame that they're not being effective enough, that they don't know enough, that they're in over their head, that they can't make sense of things, that they're frightened, that they're identifying with their patient. They can feel fear, they can feel shame about it, like something's wrong with them. So shame is a very important emotion here that needs to be identified. And and talked about in a safe holding environment so that you don't increase the amount of shame that a person is feeling. And for the therapist to be in a group or to speak with other people who do this work so that their understanding of these kinds of negatively tinged emotions that might emerge from the work.
So Bess Friedman, I believe, had to sign off, asked, at what point and how might you approach asking what an individual experiencing paranoia is trying to get, as opposed to get away from? Would it be asking, is there something good about being watched by?
Okay, okay. You're picking up on what I said. Yeah. With paranoid individuals, you might say, so it sounds like people are very interested in you and what you're doing. You might start there, right? When they have a delusional system of being followed, of being, so you're emphasizing the connection rather than the gotta get away. So people aren't, you might connect it to something that happened in the past, either that they felt people just didn't care, they were non-existent, or I had a patient whose mother had him chaperoned everywhere. He could never go anywhere on his own. And then as an adult developed this paranoid delusional system that people were following him. So he was actually repeating something from his childhood, making sure there were chaperones, although, they're negatively tinged, like they're after him or they're trying to, reveal something about him. So you would focus less on the content of the delusion and more on the activity of being connected with others.
And Molly Stewart asks, I'm curious how to approach conversations about psychosis, delusional thinking / paranoia, when an individual does not see their symptoms as such. I realize that the delicate conversation and challenging directly is not necessarily it, but any tips or tricks?
Tips or tricks? Well, one was what I just said about, trying to approach the connection, the lack of indifference. The way that I had one patient in chapter 10 in the book who said that his paranoia kept people at a distance. That he needed people there, but at an optimal distance, right? Because if they're after him, he can't let them in too close, but so we talked about that, the distance, proximity of other people in his life and what was tolerable for him, right? Let's see, what else? You can also look for cracks in the delusion. So for example, the patient that I mentioned earlier, when he said, if I am a prophet, that's a place to go in. If so, is there a part of you that wonders about that? You can just bring in the doubt. They're expressing the doubt when they say if, right? Things like that. You look for the little cracks in the armor, and those are openings where to go in. Otherwise, you're respectful. This is you ask about it, find out about it. Who are these people who are after them? What are they looking for? Why are they interested in you? What is it they want to know from you? The more you find out, the more you'll be able to, make some kind of intervention that makes sense to the person. So you go into the delusion. You either, if they're showing some doubt, you can deal with the doubt. But otherwise, learn as much as you can about the delusion itself, because that's going to tell you about their inner world, about the inner workings of their mind. And then you can, from the inside out, work from the inside out rather than from the outside in.
And so some folks have been talking about cognitive behavioral treatment and the differences and similarities, the overlaps. Robbie asks, in cognitive therapy for psychosis, the conceptualization of delusional belief is a response to a negative core belief and often expressed in his opposite. A person whose negative core belief is that they are powerless may express a delusional belief that they are a dominant political figure. Are there any parallels in how you conceptualize the meaning of delusional belief in your work?
Well, that's a good example. If somebody's insecure, feeling insecure, they might overcompensate by identifying with an omniscient figure. I'm God, I'm Jesus, I'm Moses, I'm whatever. But you see the compensatory mechanism. The difference between CBT is that they will try to logically reason with the person and show them that their reasoning is faulty. We don't do that. We don't do that. That's their reasoning. We instead will go into the reasoning, try to understand the reasoning, show them an interest in that reasoning and how it came about and what it might be functioning for them. So we don't try to dissuade them, from that and pull them towards more consensual logic and reasoning. I think that that's not a way to establish a good therapeutic alliance, too. The alliance comes from you taking an interest in the way they think, not in making them think the way you think.
I'm thinking we just have like 5 more minutes or so.
Yeah, one
That's
more.
correct. And okay, yes. So I think I'll just kind of collapse a couple or combine a couple.
Okay.
Folks have asked about social supports. In addition to therapy, as therapy is not enough, community is necessary. So I'm wondering if you might speak to that, the necessity of community supports, how you might help a individual access a community or build a community.
Yes, that's important. As I was saying in response to the person who asked about outpatient therapy, it's nice not to be alone. You don't want to get the grandiose, some people who work with psychosis are very grandiose. I had a student who was so grandiose. He was very good with psychosis, but he just thought he was the best. And one time he approached a patient after he was away on vacation and said, did you miss me? And the patient punched him in the nose and broke his nose. So that's like this, he didn't even explore with the patient what it was like. He had no idea where the patient was coming from, assumed that they could continue exactly where they were the last time. Now, when you need a humility, no matter how successful you are. Once in a while, you get knocked down. When you're working outpatient on an outpatient basis, you want as much support as you can get. Sometimes I'll meet with parents, I'll meet with partners to see what kind of support I have on the outside. I'll guide them on how to work, how to be with, how to not reinforce certain things, reinforce other things. I will suggest to people to join groups like Hearing Voices networks, or I have a bipolar patient who's in a bipolar support group. You can create your own groups now, online, anywhere. That's one of the advantages of this online World Wide Web, is that groups exist with other people who may be going through similar experiences that you are having. And so I encourage people to also join these groups so they don't feel so alone. Again, counteracting the loneliness, but also creating some external support for the treatment that you're doing with them. Thank you. Good questions. Very good questions.
Thank you. Those were great questions. And we had so many more. We could be here for hours answering them, but that just shows how meaningful and powerful people found your talk. It would be remiss of me to say Dr. Knafo has referenced again and again how important it is to connect with others doing this kind of work. And a lot of the questions we've had are kind of clinical questions. Joining ISPS-US is a great way to connect with other people in this work, as well as people with lived experience and family members who offer unique perspectives too. And we also we've launched a spring training series of 3-hour workshops in different types of psychotherapeutic approaches to voice hearing, particularly, which includes a psychodynamic class, not with Dr. Knafo, unfortunately, but with Michael Garrett. But hopefully we can have Dr. Knafo back again.
Can I just add something? If somebody is interested in purchasing the book from Routledge, you can have a 20% discount if you put in this code. F as in Frank, LYO 1.
I just wrote that down, and we'll send that out when we send out the recording. So we'll send that out. We'll send you a link to our training course. Thank you so much, Dr. Knafo. Thank you so much, Kaki, for helping too, and thank you for all your questions.
Thank you, everybody.
Julia.
Bye. Have a great rest of your day. Bye.
Bye.